talk. I first would start by acknowledging the traditional owners of all the lands on which we're meeting this morning. Now, it's a Saturday morning and we're in the middle of a COVID pandemic. I'm not going to hit you with a lot of hard scientific data, but rather take you on a journey and introduce you to some of the children that I've met along the way. So when I set out to sort of look at my career trajectory, it followed anything but a straight line from my graduation in 1980 through to today. And when I tried to sort of map this out, I found that it was very difficult to separate the personal from the professional. And what I did notice was that there was a lot of serendipity along the way, a lot of disappointments, but of course, a lot of rewards. So I asked myself, how did I end up here? In fact, I sometimes ask, where the hell am I? What influenced me along the way and where did it all begin? And to answer that question, really you have to go back to before my graduation in medicine. So I was born into a family of doctors and I was often asked, are you going to be a doctor when you grow up? And of course my answer was always no. But as time went on, I realized that although my parents worked very hard, what they did was very important. My maternal grandfather, in fact, was the first doctor to land at Gallipoli on the 25th of April, 1915. He was highly awarded, he was injured, and he was credited with developing a system of taking the doctors out to the soldiers on the field rather than bringing them in. My mother, Jane, worked with disabled children, firstly at the Cerebral Palsy Alliance, or then known as the Spastic Centre, and then Grosvenor Hospital for Children. She also worked with Janet McCready looking at limb deformities. My father became a prominent obstetrician and gynecologist, and despite a very busy clinical load, did a lot of teaching, research, and published profusely. My other grandfather, Mervyn Elliott, can be seen here lying beside the bed of Mrs. Sarah. Now, he looked after and delivered the first surviving quads in Australia, the Sarah quads. And any of you who read the journal, the Women's Weekly, will know that they were followed intensely for about 20 years. In fact, they've just turned 70. And when I reflected, they were really all clinician-scientists because they all documented and published what they did, and what they did had a great impact. So inevitably, I guess, I followed my grandparents and parents to the University of Sydney. I lived in the Women's College, where I excelled perhaps more than I did in medicine. And I did my student time and internship at the Royal Prince Alfred Hospital. Now, when I was there, I had the opportunity of doing a paediatrics term at Blacktown, and it was really that determined that I was going to do paediatrics, because I was working with the most inspirational young doctors, Toby Greenacre, Luch Della Posa, and Mike Freelander, who's now an MP. So as quickly as I could, I went to the Royal Alexandra Hospital for Children. And we then moved subsequently to the Children's Hospital at Westmead. So I've really been there since, I guess, 1981, aside from the 8 years which I spent in England. So I want to introduce the concept of life being like a revolving door. So each door, as the doors come round, each offers a different opportunity. And you can either take the doors with the known destinations, or you can take a risk and take the doors with the unknown destinations, the unmarked doors. Now, I've taken the doors to being a paediatrician, an academic, and done the routine teaching, research, postgraduate supervision, but it's the unmarked doors through which I've ventured that have really provided the greatest challenges and the greatest rewards. And I want to tell you a bit about some of those. So the first opportunity I had was to work at the Hospitals for Sick Children in London, initially as an SHO for 6 months. So I thought I was going to England for 6 months, but in fact ended up there for 8 years and came back with a husband and a baby and a container full of furniture. I was then offered a job as a lecturer at the University of London. And it was there that I published my first paper, which of course is a thrill, but a warning to you all, do check the proofs because my name was misspelt on this first paper. Now, in those days, there was really nothing yuppie about Hackney. It was an area in which about 75% of the population were Asian, poor people living in very crowded, poor housing, and gastroenteritis was rife. So I was offered the opportunity in 1984 of doing an MD thesis at St. Bartholomew's Hospital on gastroenteritis, in fact, on oral rehydration therapy. Now, this is an ancient hospital established in 1100 and something. And you can see on the right there, the big Hogarth mural, which is in the Great Hall of the hospital, which depicts a number of different diseases. Now, the reason I went to that hospital was that it was the lab there, the gastroenterology lab, was run by Tony Dawson. Tony Dawson and Sladen described the co-transport of sodium and glucose in the small intestine, such that glucose accelerates the absorption of sodium and water, and that this persists even in secretory diarrheas. Now, interestingly, we'd known this from the field from work in cholera epidemics in Bangladesh, that if you added sugar to a salt solution, it rehydrated adults and children, despite them having this massive secretory diarrhea. So, as Mary Poppins would say, a spoonful of sugar makes the medicine go down. Now, the Lancet in 1978 described this water with sugar and salt, or oral rehydration solutions, as potentially the most important medical advance of the century, because it had saved the lives of so many children. However, we didn't really know what was the most effective composition of these solutions. So I spent the next 3 years in London doing a variety of studies: human gut perfusions in cholera, animal gut perfusions in a model of cholera and rotavirus, and randomized controlled trials in children. And like Vlado, I think I was pretty well on my own, and I don't think I'd do a randomized trial in the same way these days. So we did a lot of work on these solutions, and in fact the WHO recommendation for the ideal solution now very closely follows that low sodium, low glucose, low osmolality solution with citrate as the base, which we established as the most effective for rehydration. I was working at the time with Professor Michael Farthing and Professor John Walker-Smith. Michael was an expert in giardiasis, and this led to the award for me of a Heinz Fellowship to allow me to go and live in India for 4 months and study amoebiasis and giardiasis. I actually brought the biological specimens back with me to London in my suitcase, which, again, I don't think would happen these days. Now, my husband is a child psychiatrist, and when we were visiting Sydney from London, we went to visit the CEO of the Children's Hospital at Camperdown. He, of course, immediately offered David a job, was insistent that he had to come and work in Sydney, and then looked at me and said, "Now, what are we going to do with you?" Fortunately, within the next 12 months, a job came up at the University of Sydney, and I was able to apply for that. And I then became the warden of the clinical school and a lecturer at the University of Sydney in 1991. And following on from the work that I'd been doing in London, I did a lot of laboratory work with Ted O'Loughlin. We had a model of enterohemorrhagic E. coli colitis. And one of our best publications was that we were able to show that we were able to prevent that colitis using an anti-CD18 antibody in our animal model. I had also been exposed in the UK to the British Paediatric Surveillance Unit, which had been set up very recently to monitor rare diseases in children. And I naively thought that I would establish the Australian Paediatric Surveillance Unit. So I applied for a grant, fortunately got a Ramachotty Foundation grant, and we've been going ever since. So each month, over 1,500 paediatricians in the country receive a little report card, and they're asked to let us know whether or not they've seen a child with one of the rare diseases listed. And over the 26 years plus, we've had 90% of these cards back, over 400,000 of them. We've studied 73 rare disorders, and a whole range of researchers and research institutes have used this methodology. So on the left shows the original paper card, and on the right, the electronic card, which people now receive by email. And you can see in the box there some of the studies that we're currently doing, a range of rare genetic disorders, rare injuries, rare infections, etc. Now, one example of these studies is hemolytic uremic syndrome. And because we had this system set up, we were monitoring hemolytic uremic syndrome at the time when the first outbreak, shown here in yellow, occurred in Australia. We were able to ask paediatricians to provide specimens to a national laboratory. And we established that this outbreak was caused by E. coli O111H- rather than the much more prevalent O157H7, which had been associated with hemolytic uremic syndrome. So this study provided useful information for the laboratories and the clinicians. It provided information about the clinical outcomes and presentation, and it also influenced legislation on the production code for fermented meats, because it was these meats that held this contaminant from animals. Now, I put this slide up really to say to you, as you're starting out in your careers, it's very important to have consumers involved in your work at any stage. And the Steve Waugh Foundation has been very helpful to us in helping us promote the initial developments of the National Plan for Rare Diseases. And I now sit on their committee, which we helped them establish to evaluate applications for grants for children with rare diseases. Vlado mentioned international work. I was fortunate to be able to help set up the international network of paediatric surveillance units, 14 units, which enables us to conduct simultaneous studies internationally. And more recently, in 2007, Peter McIntyre and I set up an inpatient surveillance system for serious infectious diseases and vaccine-preventable diseases. And this is now running in 7 tertiary paediatric hospitals around the country. Now, the advantage of having these sort of surveillance systems already set up is that when something happens, you can, excuse me, immediately provide some information. And this indeed is what happened when we had the influenza pandemic in 2009. We were able to very rapidly collect national data on children across Australia. And the other point to make on this slide is that we had a very small grant from the NHMRC for this project, and nevertheless, it was thought to be such valuable information that we were awarded one of the 10 of the best awards for 2013. I also, in the late 90s, had the opportunity to visit McMaster Hospital and to do a couple of weeks course in evidence-based medicine. This in turn led to an invitation to edit and the first textbook in evidence-based pediatrics and child health, which is shown here. We had 2 editions of that book. It's really important as clinicians and clinician-scientists that you can find and critically appraise evidence and then use that evidence to inform your clinical practice and policy and future research. And so this led to us setting up courses in evidence-based pediatrics and, of course, doing systematic reviews, which are extremely highly cited if they're well done. And it led to other invitations to write other books. So again, serendipity, one thing leads to another. Now, it was a phone call in 2004 from our then Governor, Mari Bashir, that got me involved in a really interesting project, which we ran over 10 years in a very remote part of northwest Vietnam, in Dien Bien Phu. This is an area which has been systematically neglected by governments. It's an area where there are 22 ethnic minority groups, and people live in very, very remote communities with poor access to healthcare, and they had no access to postgraduate education. So we conducted small group evidence-based interactive tutorials, prioritised following our needs analysis. We took up teams of obstetricians, midwives, neonatologists and paediatricians, and these were very hands-on projects. We had to take young paediatricians from Hanoi as our interpreters because no one in Dien Bien province spoke English at that time. And these were very valuable. The doctors and nurses, as I said, had no opportunity for education. They were never taught together. They were always taught in a didactic fashion. And this was a really popular course. And again, has led to ongoing work in Vietnam, in Hanoi, in the area of cerebral palsy. Another phone call came to me in 2009, this time from Jane Latimer, who Vlada would know from the George Institute for Global Health, saying that she'd recognised that I was doing work in fetal alcohol spectrum disorder, and that we had had an invitation from the Aboriginal women of Fitzroy Valley to work with them on alcohol use in pregnancy. So we set about doing the Lililuan project. This was a collaboration between Mun and Muntakura, the Women's Resource Unit, and Nindalingari, the Cultural Health Service in Fitzroy Crossing, which you can see is quite a long way from Sydney. They had developed alcohol restrictions, but having put those in place, looked around and said, now what's happening to our children? Could their behavioural and learning and other problems be related to alcohol exposure in pregnancy? And so they developed a strategy, Maralu, to diagnose and prevent fetal alcohol spectrum disorder and support families living with FASD. Maralu is a word in the Bunaba language which means precious, worth nurturing, which is what they feel about their children. And Lililuan is a Kimberley Creole word meaning all the little ones or children. Now, June Oscar described fetal alcohol spectrum disorder as a tragedy where innocent young life, the future of our people, our culture, language, knowledge about the magic creation and laws of our country are born with brains and nervous systems that are so impaired that life from birth to death is cruelly diminished. We found that 55% of children in the Fitzroy Valley had been exposed to high levels of alcohol in pregnancy, and 1 in 5 of them had fetal alcohol spectrum disorder. Despite this sad news, this study had many benefits to the community, and we were very lucky to have the support of high-profile people, Quentin Bryce, who's now the patron of the National Organisation for FASD, and Mick Gooder, who was the Social Justice Commissioner, who described this research as a genuine partnership, research done with the community, not about them, and underpinned by meaningful, respectful engagement and collaboration. And I think it was through Mick that we were invited to present our work at the United Nations at the Permanent Forum on Indigenous Issues in New York, where the Aboriginal women from Fitzroy Valley had the opportunity to understand that this was a problem faced by Aboriginal women all over the world. And this study has had lots of benefits, not only in diagnosis and clinical management of kids, prevention, but the development of a child and family centre in Fitzroy Crossing by Agawi, the ability to use these data to support continuation of alcohol restrictions, such as in Wangkatjungka, and other studies that we've performed, the Picture Talk project, examining consent for research in Aboriginal communities, Junda Yami U, introducing positive parenting programs for children with fetal alcohol spectrum disorder, the Marurd project with Royal Far West, which is looking at new models of care for remote communities, and the Biggest One project, which we're currently conducting, although unfortunately I haven't been able to get up there for some months now because of COVID, where we're following up the Lililuan kids in adolescence to see what their needs are and to listen to their voices. Now, June Oscar, who's now become our Social Justice Commissioner, said, if we want to address our most challenging problems, we need to learn to embrace diversity and work together. In the Maralu strategy, Aboriginal and non-Aboriginal people have achieved great things by working together. And in the process, we have come to understand each other's worlds. So perhaps the best outcome from this study was that we attracted the interest of politicians. One of them, Sharman Stone, initiated a national inquiry into fetal alcohol spectrum disorder, and we were able to submit our data to that study. And in fact, this inquiry has resulted in, so far, $75 million plus of money directed towards fetal alcohol spectrum disorder nationally. I've been involved in a lot of these projects. They include development of a national strategic action plan, development of a disease register, an education hub, resources for doctors, educators, and justice professionals, and a national awareness campaign. Now, one of our biggest wins last year in relation to fetal alcohol spectrum disorder was getting together a group of researchers, educators, policymakers, advocates, and consumers, parents and families, to try and persuade government to approve mandatory evidence-based warning labels for alcohol. And in fact, this is the label that is approved. Alcohol can cause lifelong harm to your babies. Of course, right up to the last minute, the alcohol industry was strongly opposing this label, which will be introduced within the next couple of years on all alcohol products in Australia. They said it was going to be costly, and they said it was going to be damaging to the industry's reputation. They were worried that it would make people feel that alcohol in pregnancy could harm the unborn baby, which of course it can cause devastating effects. Now, another door opened for me in 2014 when I got a call from the Human Rights Commission. Would I accompany the President, Gillian Triggs, and her team to Christmas Island as part of the national inquiry into children in immigration detention? Now, in Christmas Island, we found the most hostile environment, physically and emotionally. Electric fences, high wire fences, enormous crustaceans, these robber crabs, which are about 12 inches high and petrifying to children, scorpions, crazy yellow ants, and this really substandard accommodation. And you can see there are not even any windows looking out onto this corridor where people were expected to live with young children. And it's not surprising that children did drawings like this one shown here. These children were hopeless and depressed, as were their families. And Gillian and I went to see one 12-year-old girl in her little cabin. And when we arrived there, to be honest, I thought she was dead. She was a 12-year-old girl, physically abused in her own homeland. She'd witnessed an attempted murder on her mother. She'd been months in detention. Her mother had self-harmed. Her sister was failing to thrive. And her brother, so depressed, had become an elective mute. She had withdrawn. She was refusing to speak or move or talk and threatening self-harm. But she did write us a note after our visit there. And in that she said, "My life is really death. I want to die because in death, I know I can't live here anymore. If I go back home, I know they will kill me. How can I get free? I think if I stay in this room forever, because if I stay in this room, no eat, no drink, I will die. Better I kill myself." Now, as part of this inquiry, I also went to the Wickham Point Detention Centre in Darwin, in fact, with Has Gunasakara. And there we found the most traumatised children we had really ever seen, 95% of them at risk of PTSD, 100% of them at risk of developmental problems, and 95% of them scoring the highest score on the hopelessness scale, which is a good predictor of subsequent mental ill health, anxiety and depression. It was not only the older children who were able to articulate their distress. This is a 7-year-old child who had developed bedwetting, who had stopped speaking, who had stopped eating, who had developed abdominal pain. And this is her description of her trip to Nauru. And this is the description of what life was like for her in a detention centre. This is Nauru, all the people sad. We have tents in Nauru, not any houses. The fan is broken and it's hot. We don't do anything. This is me dead. I died. My dad is sad, my mum is sad. She has a baby in her tummy. She is crying, and that's the fence with the locks. This is a 7-year-old girl. And when we asked, how did she die? I jumped from the house and I died. My mum and dad are crying. all of the information from all of the immigration detention centres was put into the Forgotten Children report, which was eventually tabled by the Attorney General and said to be politicised, fabricated, exaggerated. But it was only when I was acting as a witness for a case a couple of years later that I realised that every word that we'd heard in these detention centres was absolutely true and documented in black and white in the records from detention centres. And we're still keeping children in detention. We've still got thousands of people on temporary visas in Australia. Now, our government may be tired of being lectured by the United Nations, but we have signed the UN Convention for the Rights of the Child, the rights of refugees, the rights of Indigenous people. And it's very important that we incorporate those conventions into our local legislation so that they can be enacted. Australia does quite poorly when we look at a rights scorecard for children. This one was developed by the Children's Commissioner in 2009. For example, we don't even have birth registration for many Aboriginal children. We have a lack of mental health services. The age of criminal responsibility is 10 years in Australia, and we really need to amend the Migration Act to prevent arbitrary, closed immigration detention for children. So just finally, some lessons I've learned along the way. As a clinician scientist, you do need to be prepared for rejection, but don't take it out on your mailbox or in these days, your computer. Do find a mentor. As Vlado said, dwarfs see further from the shoulders of giants. If you're a mother and a clinician scientist, you just have to accept that life is chaotic. You have to learn to compromise. Fortunately, you can't see the background here, but we live in a very untidy house. You must keep life in perspective and don't neglect your family, because your children, in my case, are really my greatest achievement. And two of them, in fact, are in medicine and one is a teacher. With privilege comes obligation. It's very important to speak up for those who can't. And finally, particularly relevant in this day of time of uncertainty, life is short, play hard. Thank you.